Hi everyone, this is Mr Neel Raithatha, also known as the Wax Whisperer. Thank you for joining me in my latest video. This is of a patient who attended, I think yesterday, if not the day before, and they were experiencing severe otalgia, which is the medical name given for an earache or pain in the ear. So I'll just give you a bit of a case summary. The patient actually saw another specialist a week prior, and with blocked ears in both ears, and the other specialist was able to remove the blockage from their left ear, but on the right ear they weren't able to really remove much. As you can see, the ear is fully blocked, and they instructed the patient to use some olive oil drops and return a week later to have another attempt. However, after using the drops for a couple of days, their symptoms just exacerbated in this ear to the point where this patient's actually a medical professional, and they weren't feeling up to going into work, and just purely because of the pain, and they weren't able to hear their patients the day before, and it was really debilitating for them, and therefore they arranged to see myself, and we got them in as an emergency. Now, as soon as I went into this ear, I knew it wasn't earwax. It may look like earwax, but it's not. It's Keratosis Obturans. It's a skin condition, and I've got a playlist on my YouTube channel, so if you just visit my playlist, you'll see that I've got quite a few cases of Keratosis Obturans, and they're the most difficult removals from the ear, Keratosis Obturans. So what is Keratosis Obturans? So keratosis is Latin, I suspect, for keratin. Well, not suspect, but I know because you can just tell. The clues in the name. So keratin is a protein that develops on the epithelial layer of skin, which is the outer layer of skin. And it has some benefits. It's normally so dead skin, as the epithelial layer of skin dies and sheds, all the fluid within that cell, what we call intracellular fluid, the cell's no longer able to contain that fluid, so that fluid leaks out the cell, and it's then replaced with a protein called keratin. So keratin, it's on our fingernails, our hairs, and so the skin in the ear, the dead keratin, should normally migrate out of the ear. Think about it in the opposite way to a snake's skin. So when a snake sheds its skin, the snake tries to wriggle and crawl out of their dead skin, and it leaves behind a cast of their exterior skin that was there previously. The ear is the same, but it's the opposite way around. So the skin in the ear canal, as it dies, that comes out of the ear. It doesn't come out all in one go like a snake's skin. It comes out a little bit on a daily basis. So the skin migrates as like a conveyor belt. Now, in some cases, really extreme cases, this skin fails to migrate. And there's many reasons for that. As we get older, it's more and more difficult for the skin to migrate anyway. The bodily functions, not just in your ear, but all around the body, they're not as active as they once were. So the skin probably does migrate, but at a slower rate. In addition, the skin's a lot drier as we get older, so there's more friction, there's more resistance there. And if you've got curly, bendy ears, the skin, as it tries to migrate around the bend, it gets trapped. Think about a river. So when you've got a meandering, bendy river, around the bends, the heavy stones and rocks, they find it more difficult to go around the bend, so they're deposited on the meanders, on the bends or rivers. Similarly with earwax, as the skin tries to migrate, when it's around the bends, some of the heavier deposits gets trapped. It can't migrate fully out of the ear. Also, some people can have abnormalities within the ear canal. And they can have widenings, erosions, and skin, as it tries to migrate, it gets trapped into one of these widenings and erosions, and it can no longer fully migrate. And eventually, this skin that doesn't migrate, it forms a plug. And the way I describe it to my patients, it's like a rubber ball. It has got that consistency, it's got that texture. As soon as you go in, it's quite bouncy. And as soon as I went into this patient's ear, I knew straight away. And it looked like wax. And when I first looked in the ear, I thought, yes, this is just wax. It should be a doddle, but it wasn't. And as soon as I touched it, I realised this is Keratosis Obturans. And I went in straight away with sodium bicarbonate drops. Now, Olive oil, unfortunately, with the Keratosis Obturans, it's not really going to do much. And in fact, when I remove this plug here, and I think you'll see a second plug near the eardrum, you'll just see a puddle of oil there. It's really wet and gooey in the ear. But it didn't really change the consistency or the composition of this dead skin. You can see this dead skin, see the plug, it's the outer sheen, that's a layer of fresher dead skin. And as you go to the core, that skin's older and it's there for longer and it's oxidized and it's formed a plug. Now, with Keratosis Obturans, one of the hallmarks is earache pain, and that's because this plug of dead skin, this rubber ball, if you like, it just gets bigger and bigger and bigger, and it starts compressing against the internal canal walls, the bony part of the ear canal in particular, to an extent where it starts to widen the bony part of the ear canal. Now, the bone that encases the ear canal is called the temporal bone. It's one of the strongest bones in the body. I think the only bones that can compete with it in terms of core strength is the fibula, I think, or the femur. And so you can just imagine how much strength and pressure this can exert onto the ear canal. And you'll see that in a moment. You'll see the widening caused in this patient's ear. You can see there's a bit of swelling there to the right, and that's a northern hallmark of Keratosis Obturans because it compresses against the canal wall, it causes bruising and inflammation. And you get 4 grades of Keratosis Obturans. Grade 1, typically it's a bit of earache, hearing loss, but there's no significant widening of the ear canal. Grade 2 is when you do get a widening of the ear canal, and of course there's otalgia, there's earache there and hearing loss. Grade 3 is where there can be a bit of bleeding caused by the Keratosis Obturans, and you get a formation of granulation tissue as well. So granulation tissue is a healing response that can occur. So when your ear's undergone trauma, with the healing process, you get a build-up of connective tissue with its own blood supply, and it's called granulation tissue. That's quite common. And grade 4 is the most severe form of Keratosis Obturans. That normally requires surgical intervention. The temporal bone, the ear canal bone, has been wide and expanded so much it then connects with the mastoid bone, which is the bone behind the ear. And that's very serious. So we've managed to remove this plug, and now the patient came in with excruciating earache. So I resisted all attempts of using any of the instrumentation because they're going to be more likely to cause discomfort for the patient. We purely worked on suction here just to maintain patient comfort, and even with the suction probe it was uncomfortable at times for the patient. Now you can see here this Keratosis Obturans phase 2 is already forming. This skin is not going to migrate, and then eventually this will form into a plug. This will be pushed into the middle of the plug, and you'll have layers like an onion of more and more dead skin. Now it's impossible to remove all the dead skin. We're going to remove as much as we can, and it's really strongly adhered. This patient will need regular appointments now, recommended yearly to 18 months, because even if they don't have any symptoms, we know just by the shape of their ear and the widening, especially at the entrance, that little cave that was there that I was removing skin from. Just here where I'm going to come back to it in a moment, I think. That's not going to allow the skin to migrate, so there's going to be a build-up, and we're going to have to remove it on a regular basis. So I'm just mopping up around the edge. The patient was over the moon. They're able to return back to work that same afternoon. I think they're on call, actually, they mentioned. This skin here, it's not fully ready to remove. I did manage to peel some of it away. And some of the aftercare, avoid water. I say that to everyone, but more so with this patient, it's more important that they do avoid water. And I've also suggested that they use sodium bicarbonate drops. Now, as I mentioned, olive oil is not very good with dead skin keratin. Instead, sodium bicarbonate drops is a lot more effective with dead skin. So they're going to use it on a fortnightly basis. That won't stop the skin from forming and developing into a plug, but it will soften the skin. So when it comes to removing it, it's going to be a bit easier. So just a bit of skin here at the front. This is the anterior canal wall. So the eardrum's nice and healthy. There's a bit of staining there because of the drops that they used, and it's turned the skin almost into a bit of caramel, so it's sticky, and we're going to leave them. We're going to try and remove that because that would be really uncomfortable. So this is that widening at the base of the ear canal. You can see it kind of, it's a trench. It goes down and it comes back up. This is a really fresh layer of dead skin. It's not ready to fully come, but just went in with a fine iron, just got as much as I can, left the remaining bits away. That's the eardrum, nice and healthy. And the middle plug, that's the large plug of dead skin that I removed. You can see the skin that's enveloped around. You can see the colour, it's really been there for a long, long time. So really stress to the patient that he needs to tan regularly to avoid it getting this bad. Well, I hope you enjoyed that video, guys. Take care, keep well. Remember, be nice and be kind to each other. Bye.